Hello, everybody. I'm Dr. Carl DeGramji. I'm professor of psychiatry, neurology, and medicine at Thomas Jefferson University. I'm also medical director of the Jefferson Sleep Disorders Center in Philadelphia. It's great to be here with you virtually as we speak about insomnia, individualized strategies in psychiatric populations, management solutions for the entire care team. These are my faculty disclosures. Here are our learning objectives. Today, we're going to outline the real-world prevalence of insomnia in psychiatric populations, and we'll be reviewing tactics for insomnia recognition and screening in both primary care and psychiatric settings. We'll also analyze the pathobiological targets of current and emerging insomnia pharmacotherapies, including GABA-based therapies and orexin receptor antagonists. We'll also construct individualized treatment plans for patients with psychiatric and mental health disorders that considers safety, concerns, and individual patient and disease characteristics. Insomnia disorder. This is the problem or disease entity that we'll be dealing with. What is insomnia disorder? Note, by the way, that it's now referred to as a disorder. Number one, dissatisfaction with sleep quality or quantity with at least one of the following symptoms: difficulty falling asleep, staying asleep, or waking up too early in the morning and feeling that you can't get back to sleep. It's any one of those. Significant distress. We have a number of individuals who have difficulty sleeping, but there's no distress, there's no impairment during the day. Technically, that's not a disorder. Frequency of more than 3 nights per week, lasting 3 months or longer, and adequate opportunity to sleep. Some people sleep deprive themselves because of shift work or job issues. That technically is not insomnia. Note that on the very bottom, we can specify the coexistence of other disorders, which we call comorbidities. Mental disorders, depression, anxiety disorders, and so on, medical comorbidities, other sleep disorders. And so insomnia disorder can exist as an independent entity in the context of other medical and psychiatric disorders. Put it another way, the presence of other disorders does not necessarily rule out the possibility of coding or having an independent or coexistent comorbid insomnia disorder. Here's an example of a patient who has a history of major depression who meets diagnostic criteria for insomnia disorder as well. 71-year-old man with a history of major depression. He presents to us with unexplained weight loss, anhedonia, anger outbursts following retirement, and of course with a complaint of insomnia. No medical comorbidities. He has repeated awakenings in the morning, can't fall back to sleep around 5 a.m. after awakening. Onset 4 months ago, frequency 4 to 5 nights per week. So he meets duration as well as frequency criteria for insomnia disorder. His mind spins at bedtime, very common with insomnia patients. They have this hyperactivity of the mind. He feels washed out during the day, so there is that more daytime impairment. Low energy, mood is irritable. So a lot of, you can see his mental status examination goes along with depression, with psychomotor slowing. So a number of these symptoms can go along with depression. In fact, he meets depression criteria, but also meets insomnia disorder criteria, and we can code both at the same time. Insomnia disorder plus depression, major depressive disorder. So insomnia is a common problem in the community. We note that about a third of the population, 33%, complains of insomnia every single night. So it's a common disturbance every single night for long, long periods of time. And about 25% of the population has it a few nights per month. The problem is compounded by the fact that insomnia is the second most common health-related complaint. So it's a very common problem seen in clinical settings quite frequently. In the primary care arena, almost half of all patients have insomnia as a problem. What's interesting about this is that most of these patients in the yellow pie graph here, most of these patients do not report insomnia to their primary care physicians. It goes unaddressed, and only a third of patients actually mention it, and about 5% seek treatment. So by and large, insomnia, although it's a common problem, remains unaddressed and undetected in clinical settings, primary care clinical settings. This is also true of the psychiatric arena. This was a study of an outpatient psychiatric setting with 400 outpatients, meeting criteria for depressive disorder, bipolar disorder, anxiety, schizophrenia, spectrum disorders. 32% met diagnostic criteria for insomnia disorder. So a third of them had the disorder. And most of these folks had a depressive disorder, although many had anxiety, schizophrenia as well. What's also important is that the presence of insomnia disorder predicted greater impairment in daytime functioning in this population. So insomnia is a complication in terms of clinical settings because it does introduce an additional morbidity for our patients because they have greater problems with daytime functioning, well-being, and daytime fatigue. So it is common in outpatient psychiatric settings. It's also very common in inpatient psychiatric settings. This was a study which we did in our institution, looking at about 100 inpatients who had various psychiatric diagnoses, and 79%, almost 80%, had insomnia as a major problem. They met threshold criteria for insomnia based on the insomnia severity scale. And the various subscales you see here define the type of insomnia that they had. DFF, difficulty falling asleep; DSS, in green, difficulty staying asleep; PWE, problems waking up too early. All three categories of insomnia, initial, middle, or late insomnia, were defined in this population. And if you go to the very end, the SPI, sleep problems interfere with daytime activities. 85% said that sleep problems interfered with daytime activities. What was also notable about this study is that none of the clinical charts, 0 of the clinical charts, actually identified insomnia as a clinical problem, even though 80% had it, or 80% had it, and most of them defined this as a problem which caused interference with daytime activities. This is a real issue for us as mental health professionals. We also do not detect insomnia commonly. We do not identify it as a clinical problem. Now, in our subpopulations of various categories, diagnostic categories, insomnia has different characteristics. I'm going to be speaking about depression in a couple of minutes, but focusing on anxiety disorders, insomnia is common and causes this sense of being jittery, being unable to settle during bedtime. In ADHD, insomnia is also very common. It causes ADD and ADHD patients to wake up a lot, and the thought is that that may have a circular relationship with their ADHD. So waking up a lot may actually foment or exacerbate or worsen ADHD symptoms. Same with PTSD. PTSD patients cannot sleep well or wake up a lot because of distressing nightmares and phobic avoidance of these dreams, and that may cause further insomnia and daytime performance issues. Let's just focus on depression. I'm going to skip this slide for a couple of minutes and come back to it. Let's just focus on depression for a couple of minutes. Insomnia is a common complaint in major depression, and what's interesting about insomnia is that it tends to occur usually before the onset of the depressive episode. So way before the onset of depression, insomnia often begins and foments, and depression comes along many, many months or years later. So it's important to identify insomnia and to look for the possibility of depression in these chronic insomniacs. The presence of insomnia in the context of major depression is associated with a higher rate of lifetime and current major depression and predicts future depressive episodes. In addition, it predicts worse outcome. The presence of depression predicts persistence of depression, refractory depression, chronicity, and even suicidality. In the context of bipolar depression, the presence of insomnia predicts a shift into mania. So it's very important to monitor insomnia in the context of bipolar depression, because if it occurs, that patient may have a higher likelihood of recurrence into mania. A couple of data points. These were studies which looked at insomnia patients and followed them long term, and then detected the onset of depression. You can see the odds ratios in each of these studies, all the way on the right side, are higher for patients in terms of occurrence of major depression if they have chronic insomnia. So chronic insomnia is associated with a future risk of depression, even though currently these patients may not be depressed. The additional aspect of insomnia is that it often complicates residual depression. I apologize. It's often a residual symptom of remitted depression. These were patients who were all treated, who had depression and were treated, and they met criteria for remission. That is, depression by all accounts had remitted, had gone. They were treatment successes. But note, the most common residual symptom that they have is a sleep disturbance. So they could not sleep well, they woke up a great deal. So even the depression resolved, 50% of them still had a disturbance in sleep. So insomnia is often a residual symptom in patients who have remission from depression. And what's important to remember is that the presence of residual insomnia predicts the onset of another depressive episode. These were individuals without sleep disturbance after treatment versus those who did have a sleep disturbance after treatment. Notice the recurrence rates are much higher for those into depression, are much higher for patients who have a sleep disturbance. So clinically, I think it's very important to follow patients after the resolution of their depression. If they have sleep disturbances, it may be very relevant to manage these, to be able to provide some relief for the patient and possibly even avert another depressive episode, although we don't have a lot of great data that show that. We do have data, interestingly, showing that patients who are co-treated for insomnia in the context of depression may have some benefit in terms of mood. I'd like you to focus on the third bullet point. This was a study of depressive patients who were treated with fluoxetine or placebo, and they also received S-zolpiclone. So they all had fluoxetine on board, and they were randomized to receive either S-zolpiclone, which is a sleeping pill, obviously, or placebo. The patients who were co-treated with S-zolpiclone had a higher overall major depression remission rate. So the folks whose sleep improved, in essence, with S-zolpiclone had lower remission and had higher remission rates in terms of major depression. What this says to us is that treating sleep in the context of depression, managing sleep, may have direct benefit in terms of mood in the patient with major depression. Now, S-zolpiclone is not approved as an agent for the treatment of depression, obviously. But the point of this slide is that sleep may be an important parameter to follow in terms of treatment in patients with depression, because we may be able to help them even further by benefiting them in terms of insomnia. Insomnia is also a risk factor for suicide. We have data showing us that longitudinally, that patients who have insomnia are at greater risk for suicidal ideation and also death by suicide. And the mediators are difficult to define, but they may be this sense of thwarted belongingness and hopelessness. Even factoring out for depression, patients who have who have insomnia are at higher rates, have a higher risk for suicidality. Now, what's also interesting is this recent study by Dr. McCall and his colleagues showing that patients who are treated, who are suicidal, who have major depression and suicidality with insomnia, who are treated for their insomnia, may have a reduced risk for suicidality. On the left-hand side is the suicide ideation aspect of the scale for suicide ideation. And on the right side is the Columbia Suicide Severity Scale. And we're looking at the suicidal ideation aspect. Notice that on the right side, the Columbia Suicide Severity Rating Scale shows benefit in terms of suicidal ideation in patients who are actually treated for insomnia. In this particular case, Zolpidem CR was utilized, compared to those who were only treated with placebo. This benefit was not noticed in the left side with the scale for suicide ideation. So again, the important point being that managing insomnia in the context of major depression may be important for imparting some benefit even in suicidal ideation. So sleep is important to manage in the context of depression and suicidality. Now, negative outcomes also exist in other realms in insomnia. Chronic insomniacs have a predilection for diminished ability to enjoy family relationships. They have a decreased quality of life. They have increased absenteeism. Their job performance suffers. They also seem to have a greater risk of accidents, motor vehicle crashes, increased falls. Healthcare costs are higher in insomnia patients. On the right side, impaired concentration, incidence of pain. Interestingly, not sleeping well makes patients more sensitive to pain stimuli. So, and the converse is true too. Helping patients sleep more often decreases their sensitivity to pain. So managing sleep in the context of chronic pain may be very relevant. Physical disturbances. Chronic insomniacs have a higher rate of development of hypertension in the future and diabetes as well. And of course, mortality is a risk as well. Here's some of the data showing those driving accident issues that I described earlier. These are data looking at standard deviation of lateral position, which is a measure of sway when driving. And on the top, you see insomniacs in blue. On the bottom, good sleepers in orange. Good sleepers have lower levels of sway. That is, when they drive, they don't weave as much. Their driving is more accurate. So insomniacs have more difficulty with driving, presumably as a result of not sleeping well and the cognitive issues that produces. After 4 years of having insomnia, insomniacs are also more likely to develop hypertension. And we don't understand why this is, but it might be because of the nature of insomnia, which is, we know insomnia is a disorder of central nervous system hyperarousal. All sorts of brain activation takes place in various parts of the brain. We can see this through imaging studies. And we think that this activation translates into sympathetic hyperarousal, which in turn might translate into hypertension. So insomnia is a risk for various metabolic as well as cardiovascular impairments in the long run. So having said that, I hope I've convinced you that it's important to look for insomnia. How do you look for insomnia? How do you detect it? The screening for insomnia is very simple when you think about it. All you really have to do is ask the patient, do you have difficulty falling asleep, staying asleep, or waking up too early? Very, very simple. Or do you feel that sleep is unrefreshing? A yes answer to any of these things, any of these questions, raises the possibility that the patient may have an insomnia disorder. And then we can ask them more questions about frequency, duration, and whether it in some ways translated into impairment. And all those yes answers, of course, give us a diagnosis of insomnia disorder. Another way to quantify this more rigorously is the Insomnia Severity Index. This is commonly used in the field of insomnia therapy and insomnia monitoring, diagnosis and monitoring. And it's a scale which can rate the severity of insomnia as well. You can actually follow patients therapeutically over time with this scale to see if your therapies are improving their insomnia or not. A score of 8 or above gives us a positive indicator for insomnia, and 15 and above is clinically very relevant insomnia. Now, an algorithm which I'd like to recommend that all of us use once we detect insomnia is this algorithm, which I published a number of years ago. Once we detect the presence of insomnia, I think it's important to do a couple of different things. First of all, to detect details, to go into details about the course of insomnia and the type of insomnia over the course of that single night. Is it initiation insomnia or maintenance insomnia? Secondly, does the insomnia contribute in any way to daytime functioning problems? Obviously, if it does, then that means that patient is more the one who should be managed more aggressively. Going to the right, the light blue areas, we should also identify comorbidities, because treating the comorbidity is a very important step in potentially resolving the insomnia. Going on a little bit to the top of the slide in the green area, treating the comorbidity first is very relevant, but sometimes we can also think about treating the comorbidity and the insomnia at the same time. And as I mentioned before, in some cases, that provides even greater benefit in terms of the comorbidity itself. And finally, what types of treatments should be utilized? And we'll talk about this more later. They fall into the realm of behavioral, cognitive behavioral, as well as pharmacologic therapies. And we'll review which might be better to try first versus second. So this, I think, is a nice algorithm to summarize detection of insomnia, how do you work it up, and then what do you do in terms of management. And let's talk about comorbidities. Insomnia, as I mentioned before, is usually associated with many, many comorbidities in clinical settings. The health conditions, as well as the attitudes and beliefs about sleep, cognitive distortions. Insomniacs may have the misperception that they need 8 or 9 hours of sleep, may have the misperception that not sleeping is extraordinarily dangerous immediately to their health, and they could tend to catastrophize. And on the left side, medications, substances. So we need to be, to some extent, detectives when we look at insomnia, being able to uncover these underlying comorbidities, to treat them conclusively, to hopefully to be able to overcome insomnia. This is an example of a patient with comorbidities, patient who complains of insomnia. She's 27-year-old, happens to be vegan, suffered from insomnia, initiation maintenance difficulties for 5 years or longer. Family physician treated her with 3 benzodiazepine receptor agonists with no improvement. And she also has a history of anemia and iron deficiency. Her ferritin is low, which is a diagnostic clue. And she also has GAD, generalized anxiety disorder. She's on fluoxetine with relief generally from the anxiety, but her insomnia persists. We saw her in the sleep medicine clinic, and we did a polysomnographic study or sleep study. You can see the results on the right side. Those little blips, black blips, represent almost spasms, if you will, on the leg leads, lower limb leads. These are called periodic limb movements, and they're occurring at periodicity of every 10 seconds. And we defined her as having periodic limb movement disorder, which is a disorder very similar to restless leg syndrome. And we treated her with dopamine receptor agonists, which resolved symptoms within 2 days. So the point being made that insomnia is often associated with comorbidities, which have to be detected and treated for the conclusive resolution of the disorder. I mentioned before that the pattern of insomnia over the night can give us a clue as to diagnosis. And here are a couple of examples, a few examples. Initiation insomnia, initial insomnia, is often associated with circadian rhythm disturbances, delayed sleep phase syndrome, which occurs in youngsters who have a schedule delay, which needs to be treated. Middle insomnia can be a diagnostic clue for depression or sleep apnea or periodic limb movements in sleep. Terminal insomnia, late insomnia, could be a clue for a shift worker or an advanced sleep phase syndrome, older individuals who fall asleep quickly, but then wake up early in the night and can't fall back to sleep. And this also can tell us a bit about therapy, because agents that treat the middle of the night problem are different than those to treat the initial part of the night, and some agents that treat both the beginning and the middle of the night. So selection of pharmacologic agents could be helped by looking at the pattern of insomnia over time. We can also get some clues of the pattern of insomnia from sleep diaries. These are available online. This is an example of a patient with a delay in their bedtimes in the weekends, which are the bottom two portions of the graph. So this person is having normal bedtime hours during the week, but on weekends sleeps in late. And the violation of sleep hygiene, if you will, by sleeping in, is one of the causes of insomnia of this patient. And we can also get a more objective pattern of sleep by actigraphy. These are wristwatches which monitor motion and which can give us a clue about the patient's sleep-wake patterns, especially for patients who are not reliable in terms of their history. Now, I'd like to now go into the neurophysiology of sleep and then into pharmacologic and non-pharmacologic therapies. The whole area of arousal, that is the awakening system, is governed, as many of us know, by various neurotransmitters. These are in the realm of histamine, dopamine, norepinephrine, acetylcholine, and so on. There is another system which some of us may not be aware of called the orexin or the hypocretin system. This is in red. And this system, I'll talk about a bit later, seems to be an important system in terms of regulating and coordinating this arousal system with the sleep system, which now appears on the right side of your slide. The sleep system, the neurotransmitters that generate sleep, if you will, are primarily located in the VLPO, or the ventral lateral preoptic nucleus in orange on your slide. And that's innervated primarily by GABA, gamma-aminobutyric acid, an inhibitory neurotransmitter in the brain. So the balance between these GABAergic neurotransmitters on the one side and the activating neurotransmitters on the other side, this balance defines whether or not we are asleep or whether we're awake. And the orexin or the hypocretin neurotransmitters, these are synonymous terms. These neurotransmitters govern this balance between the two, or predict whether the balance shifts in one direction or the other, and at the same time stimulate arousal or cause arousal when we're awake. These hypocretins or orexins, neurotransmitters, are, as I mentioned before, hypothalamic peptides. They have wide projections throughout the brain, and they impinge on top of the other activating neurotransmitters. They not only mediate arousal, but they also mediate locomotion, metabolism, and blood pressure, a number of other important functions of living. And as I mentioned before, they also activate the brain. They also define this balance between whether we're asleep or whether we're awake. On the top of this slide is this sort of seesaw diagram showing us how the balance is now favoring arousal or wakefulness, because the hypocretin orexin systems are switching on this sleep-wake switch. On the very bottom of the slide, the hypocretin systems are less active and therefore diminishing wakefulness neurotransmission and favoring sleep. So they define when we're asleep and when we're awake in this flip-flop fashion, so that the switch is either basically on or basically off. Very important set of neurotransmitters. Their net effect is to promote wakefulness, but when they're off, they promote sleep. Now let's go on to the next slide to show us the neurophysiology of insomnia and whether it may or may not be related to the hypocretin orexin systems. So these orexin systems, as I mentioned before, favor activation or wakefulness. And there's some interesting data showing that they may be these orexin systems may be elevated in plasma in patients with chronic insomnia disorder. So these data are not definitive and need to be looked at a bit more to be able to define them, and also especially to be able to look at the CNS levels of these orexin systems in insomniacs. But the suggestion is that the orexins may be hypertrophied in insomnia patients, and that neurophysiologically they may be related to why insomniacs have insomnia, this overactivation of the brain. More work needs to be done on this to define the relationships between orexins and insomnia. Okay, now, once we've identified insomnia, where do we go for treatment? Well, we think we can either start with pharmacotherapy or start with cognitive behavioral therapy. And in this slide, I've laid out some considerations where we might want to start with pharmacotherapy first or start with cognitive behavioral therapy first. In general, if a patient has a need for rapid improvement, pharmacotherapy is preferred. Pharmacotherapy is also optimal for patients who do not have specific cognitive behavioral issues to treat, or it's often used also in areas where there's a shortage of trained therapists. On the other hand, CBT is optimal for patients who need long-term benefit, sustained benefit. Data clearly show that with CBT, we can produce benefit after the termination of CBT therapy for up to 2 years. Also, CBT is very helpful and desirable if patients have substance abuse issues or have a lot of medical comorbidities. So we might want to think about when to select each of these therapies based on the patient's characteristics that I've defined here. Now, CBT is a multimodality. It can be in the realm of stimulus control therapy, relaxation therapies, sleep hygiene education. I'm not going to go into these in great detail, but I'm going to basically stress that it's important to know a little bit about each of these therapies to be able to tailor the type of CBT for that particular patient. Let's just talk a bit about CBT in terms of sleep hygiene, because these behavior modification areas can be helpful in modifying the patient's insomnia. Getting up out of bed at a regular time every morning is critical, because that resets the circadian pacemaker for all of us and defines whether or not we'll be falling asleep at the right time the next night. Increasing exposure to bright light in the morning is very important. And as a corollary, diminishing bright light in the evening and making sure the evening is a relaxing and dimly lit time for us. Setting worry times for us, which are important for us to be able to take away some of that concern that we have that seems to engage us at bedtime. So worry times are better. If we schedule worry times, it's optimal as opposed to letting the worry bombard us when we go to bed in an uncontrolled fashion. and doing relaxing things prior to bedtime, avoiding substances that may be damaging to sleep, such as alcohol, caffeine, and eliminating as much as possible bright light in the evening hours, and doing away with those heavy meals, and limiting drinking fluids close to bedtime. So these are some things which we might want to help our patients with, and they help a great deal in some patients, and they also augment our own therapies. So hypnotic agents, for example, may not work well if the patient is violating sleep hygiene rules. Just wanted to stress that cognitive behavioral therapy is the gold standard for treatment of insomnia, and also has been shown to work in 8 weeks of therapy. There are now some online systems. The one that I'm familiar with is Somryst. It's been introduced after being approved by the FDA. I don't know that it's yet ready for prime time, but it is available online for patients it will be available for patients to utilize online. Of course, it does require some funding on the part of patients when therapists are not available. There's also something called brief behavioral therapy for insomnia. BBTI is now undergoing trials to be delivered entirely via telehealth. There's some apps as well. The one that I use commonly is called CBTI Coach, CBTI-Coach. It's an app which is helpful for patients who have insomnia. It's free. It gives them it gives them some guidance in terms of sleep hygiene, education, and also has some sleep logs that patients can chart their sleep-wake times and help you monitor as well. Meta-analyses for CBTI clearly show that CBTI is helpful. Sleep onset latency improved by about 20 minutes in this meta-analysis. Wake after sleep onset, that is the amount of time they wake up after they fall asleep, improved by 26 minutes, and their total sleep time improved as well. So it's important to know that it does help. It also provides sustained benefit. Non-traditional therapies, these are the sort of homeopathic agents, are often utilized by insomniacs. Here's a patient of mine, 80-year-old woman, a married woman who complains of initiation maintenance insomnia way back since the age of 24. She takes citalopram for chronic anxiety, and her chronic anxiety disorder is well treated. She also, for her insomnia, is on trazodone, diphenhydramine, which have not worked the next day, which have not worked well, so she discontinued. Now she takes a pill containing valerian, hops, chamomile, and she now complains of continued insomnia and asks me, are there any other natural products you can recommend? What about melatonin? What about tryptophan? So there are these consumers who have tried everything and will try something and will mix things together. Commonly, this is a common practice by our patients. What's the right answer? Well, unfortunately, not a lot of data. I'm going to show you 3 slides which categorize these various compounds into 3 separate categories. The first one are the agents where there's a relative index of safety, and there's some data suggesting they may be helpful or beneficial. The second category are the agents that actually do not have sufficient evidence for efficacy. And the third category are the agents which have some real concerns in terms of safety. So going back to the first set of agents, valerian, diphenhydramine can work, might work. They have some side effects listed on the slide. Be careful about them. But these are agents which may be beneficial for some patients. The second group of agents I mentioned before, there's really no evidence that they work. Things like St. John's wort, magnesium, vitamin B12, hops. So you may want to really rethink these if patients are on them. And the third set of agents really can introduce some side effects which are of some concern. Alcohol we all know about, obviously. Wild lettuce, possible hallucinogenic effects. Calcium, 5-hydroxytryptophan, and kava is actually outlawed in some countries because of its hepatotoxic effect. So it's important to monitor for these in case the patients are on them. What about melatonin? Meta-analyses with melatonin in run-of-the-mill insomniacs have shown modest effects. It can decrease sleep latency by about 7 minutes. It can also increase total sleep time by about 8 minutes. Again, not a robust effect, but it's something to think about as a possibility. Again, remember with melatonin, if patients are on it, they might have some side effects as well, right? Think about also the fact that it might impair glucose metabolism in younger children, it may affect their ability, their testicular function. So it's not devoid of side effects. I generally favor, if people will be using melatonin, I favor the practice of limited periods of time and at lowest doses possible. What about trazodone, commonly used compound that casts a wide net, a lot of receptors, a lot of sedating effects. There are not a lot of studies showing us that it works definitively, but anecdotal data showing us that in some patients it might work. If you do use it, remember efficacy is not well established, and it can have some side effects, including daytime sedation, so you need to be a bit careful. What about low-dose atypicals? Quetiapine is very commonly used as a sedating agent. Again, not well studied. Think about some side effects that you might introduce to your patients, such as anticholinergic side effects, weight gain, and my concern, obviously, in many patients are these lipid abnormalities, glucose abnormalities, monitor blood sugar, make sure that lipid is being followed carefully. EKG, might want to get an EKG. What about the prescription agents for insomnia? These are prescribed, indicated for insomnia as well. We have on the left side, top left, the benzodiazepine receptor agonists that are benzodiazepines in their molecular structure. The older agents, estazolam, flurazepam, and so on, all the way to triazolam. The newer benzoreceptor agonists, which are non-benzodiazepines in their molecular structure, but they still act at the benzoreceptor. S-zopiclone, zaloplan, zolpidem, and finally the zolpidem extended release. These are excellent agents. They generally work. Some distinctions between the two. S-zopiclone and zolpidem extended release are the only two agents that work for both initiation and maintenance insomnia. Zaloplan and zolpidem are really indicated only for initiation insomnia. Going to the right side of the slide, some new formulations of these Z drugs. There's an oral spray, a sublingual version. The sublingual version, which is the 1.75, 3.5 milligram dose, the low dose sublingual, trade name Intermezzo. Interesting drug because patients can take this after waking up in the middle of the night so that they can get back to sleep in case they have not had enough sleep, as long as they have 3 or 4 hours ahead of them. So something to think about as a PRN middle of the night drug. And finally, the Romeltion and Doxepin. These are non-scheduled drugs. Doxepin is indicated for initiation insomnia, Romeltion for maintenance insomnia, non-GABAergic drugs, very new drugs, and the newest of drugs, the orexin receptor antagonists. Remember, we spoke about the orexins or hypocretins as activating neurotransmitters. By muting these, we can actually increase sleep and produce sedation. Not sedation, but produce sleep, excuse me. The newest drugs are Suvorexant and Lemborexant. These are orexin receptor antagonists. We'll talk about these in a couple of minutes. These are some side effects to think about. You may want to review these afterwards in your handouts that you get. It's important to make sure that you're aware of these for insomnia patients. Let's talk about the orexin receptor antagonists. The one that was introduced a few years ago was Suvorexant. It was approved in 2014, actually. It's onset and maintenance insomnia medication. These are some of its side effects. It, interestingly, has been shown to have no difference from placebo in some of the morning performance measures. So there's a safety advantage for this drug. It also has been recently studied in Alzheimer's patients for insomnia, has been shown to have some improvement as well. One of the other safety measures for this drug is that it's been shown to have some safety in patients with mild to moderate sleep apnea, breathing disturbances. So even though it has this safety advantage, I caution all of you to make sure that your apnea patients are well treated for apnea if they have a sleeping pill on board, regardless of which sleeping pill you're using. Lemborexant, the newest medication to be introduced in this class of orexin receptor antagonist, just approved December of 2019. Again, a scheduled drug just like Suvorexant. It also antagonizes both orexin receptors, very low incidence of daytime sedation side effects. Again, no difference from placebo in terms of some safety measures. For example, driving performance the next morning or body sway imbalance the next morning. No, it does not seem to have those residual side effects the next morning, which we associate with safety issues with some of these other older drugs. Also, awakening in the middle of the night was no different from placebo. So patients who need to wake up in the middle of the night, shift workers, for example, there may be some advantage to this medication. The studies which were used for this bring this drug to fruition were these two large studies. The first one was one that studied objective sleep parameters such as time to sleep onset and sleep efficiency and wake after sleep onset, sleep study parameters for a month. And the second one was a 6-month study looking at subjective parameters. And both studies obviously demonstrated improvement in these parameters with this drug. This drug also had some safety advantages in the sense that it did not seem to impair breathing and COPD, mild COPD and mild sleep apnea, but in moderate to severe apnea, this drug has not been yet studied. A special note on geriatric patients. Concerns are many in terms of daytime sedation after taking these drugs, nighttime impairment after they wake up and get up to go to the men's room or ladies' room. So it's important to be careful about these drugs. The American Geriatric Society has recommended these drugs be avoided, the ones on this slide, the Z drugs, the diphenhydramine doxylamine, doxepin, greater than 6 milligrams, and the antipsychotics. So it's important to think about these medications, whether or not these are optimal choices for patients who are elderly and who may have cognitive and motor impairments after taking these drugs. Complex motor behaviors with the Z drugs. So the FDA has identified this as an area of concern. Patients who take Zaloplan, Zolpidem, or S-Zopiclone specifically, and have histories of walking in their sleep, having motor vehicle crashes while driving their vehicles, again, seeming as though they were in a soporific state, somnambulistic type behavior, getting up and walking and then falling and injuring themselves. The drugs listed on this slide in the second bullet point have black box warnings, warning against the use of these drugs in patients who may have histories of complex behaviors and being very careful about these drugs. There are also warnings for all the sleeping pills, general non-box warnings for these particular types of behaviors. The behaviors are more common in patients who have a history of these behaviors, like who have a history of complex behaviors already, or who are drinking alcohol, using other sedatives while taking sleeping pills. So be careful. You warn your patients very carefully about the possibility of these, especially if they have sedatives on board or if they've had these behaviors in the past. I mentioned to you that morning driving has been a positive safety factor for some of the newer drugs, the orexin receptor antagonists in particular. And this was a slide just to show you how morning safety from driving is assessed. Basically, patients are put in a car and they're asked to drive, and this sway factor is assessed, the degree of sway. And the greater the sway factor, the greater the impairment is thought, the greater the level of impairment from that drug. Body sway was assessed with some of the newer drugs, such as lemborexant. Driving the deviation, I should say, was assessed with lemborexant the next morning, and in general shown to be fairly equivalent to placebo. But again, any drug can produce morning sedation in any patient, so it's important to warn patients about driving the next morning, especially those who are elderly. They may have a greater tendency to do that. Now, finally, what are some disease characteristics which we can use to identify what drug to use in a particular patient? Now, a lot of drugs available for us. Which drug do we use for which patient? Well, the age. Some drugs have been studied for older patients. For example, the orexin receptor antagonists have been specifically studied in older populations. What about sleep onset insomnia? Well, the ones indicated for it are Ramelteon, Zolpidem, and Zaloplan. What about just maintenance problems? Patient says he wakes up a lot only, but has no problems falling asleep. Well, doxepin low dose may be an appropriate agent. Or in the middle of the night, using Zolpidem low dose. You wake up in the middle of the night, you take the Zolpidem low dose and go back to sleep. What about patients who complain of all types of insomnia, problems falling asleep and staying asleep? Well, these are the medications indicated for that. S-Zopiclone, Zolpidem extended release, Suvorexant, and lemborexant. What about patients who need to wake up in the middle of the night? Well, doxepin low dose or lemborexant or Suvorexant. Again, It's a concern still. You can't say to patients you're safe completely, but if you have to wake up every once in a while in the middle of the night, these may be the drugs to try, but still be careful once you do get up. What about patients who have comorbid respiratory conditions? Here are some drugs to think about: Melatonin or Suvorexant or Lemborexant in mild obstructive apnea. Patients with substance abuse, Melatonin, Doxepin are not scheduled agents. These may be desirable. And of course, patient preference and cost are factors as well. There are some drugs that are emerging as treatments for insomnia, and these all fall within the orexin receptor antagonist class. Daridorexant, Seltorexant, it's now undergoing clinical trials. It's also being looked at for patients with major depression adjunctively to antidepressants. We don't have a lot of data yet, but hopefully we'll be able to see these soon. So there are a number of different medications now available, and hopefully with the array of medications available, we can possibly identify defining characteristics with specific patients, which can guide us identify which agent may be the desirable first choice agent for that particular patient. So in conclusion, some practical takeaways for us today. Insomnia is highly prevalent in our psychiatric populations as well as in primary care populations. We see a lot of insomnia, and it's associated with negative outcomes, not only outcomes in terms of the psychiatric comorbidity, but also in terms of their ability to function during the day and in terms of medical comorbidity as well. Unfortunately, it's poorly identified by all of us in clinical settings, and patients don't complain about it. We often don't ask for it. And the best way to identify it really is to ask, how is your sleep? Have you slept? Do you sleep well? Do you wake up feeling tired the next day? Do you have difficulty falling asleep, staying asleep? Once we identify it, though, it's really important to engage in a systematic evaluation to find out what its comorbidities are and the nature and pattern of insomnia. Finally, there are many treatments available: cognitive behavioral therapy, pharmacologic therapy. These are all rational choices. And what's really great now in this day and age is that we can now begin to tailor the treatment strategy for a particular patient based on the patient's clinical characteristics. So by looking into the patient's clinical presentation and characteristics, we can figure out what might be the best medication to treat them with. I'd like to leave you with a patient of mine in the next video who's a 67-year-old woman who came to me with a complaint of unrelenting insomnia. She'd had this insomnia for decades. It turns out that she also suffered from an anxiety disorder, social anxiety disorder, which was successfully treated with a combination of an antidepressant and cognitive behavioral therapy. So that disorder had resolved, but her insomnia persisted. And she came to me, and we did a very sort of a detailed workup. We found out that she had some sleep apnea, difficulty with breathing during sleep, and we treated that with a CPAP machine. Lo and behold, her insomnia did not go away. So we treated the comorbidity, the medical comorbidity, her insomnia remained. And this is a woman who had been refractory to many sleeping pills. We finally put her on an orexin receptor antagonist, and she did quite well. And here she is describing how well she did following treatment.
I do still have the occasional sleepless night. I almost always get at least a couple of hours of sleep. But in general, I sleep 6 to 7 hours a night, and sometimes even 8, which is really nice. I wake up almost always at least once a night, but that's still so much better than 3-4 times a night. And when I wake up in the morning, I almost always feel a lot better and I feel refreshed, and I'm not tired. I'm able to go on vacations again with friends, and they've all told me that I don't disturb them at all. They don't hear me snoring anymore, which is probably the biggest benefit to me.
Okay, well, I'd like to thank all of you for joining me today, and I'm really looking forward to the next section on questions which you might have for me on this presentation.